I think we'll move on to the last talk by Dr. Vinay. I have learned most of my surgeries under him, and he's been patiently standing in the earlier days on the sideboard telling me what to do and what not to do. So thank you so much, sir, and over to you.
Thank you, Shweta. Good morning, one and all. Good morning, madam. Great to have you here. And sir, we have broken the ceiling. We have got, people more than speakers here. So, welcome to all. When Shweta asked me to speak on this, I was wondering, what shall we speak on stem cell, or rather limbal transplants? It's very evident, it's very known. But then, what does limbal stem cells mean? Or we know the corneal epithelium, the conjunctival epithelium. There is a limbus in between. So, the cells from this part is what helps to maintain the cornea normal or the corneal surface normal. And when the function of this limbal stem cells or the limbal epithelium goes off, we have the conjunctiva coming into the cornea, resulting in drop in vision or loss of vision, persistent or recurrent inflammation, recurrent epithelial defect, which go in for persistent defects, melt, perforation, so on and so forth. So lots of problems there. Over the last 30, 40 decades, people have worked on it and come out with lots of information, which has actually revolutionized management of these difficult cases, if I may say so. It was in the early 70s when people realized that the limbus is the seat of the basic normal corneal epithelium where originates from. Then it was cultured. Then Toff came out with the XYZ hypothesis. Then from human limbus it was cultured. Then Kenyon and Seng transplanted the limbus. So on and so forth, it just went on. Even in the early 60s, Baracker, would describe the epithelial limbus conjunctiva corneal taken from the other eye for treating superficial burns. So it was, in the 89 when Kenyon and Seng described the limbal autograft, which is even today probably we may say as the gold standard for comparison for any of limbal transplant procedures. This is the one which has actually revolutionized our management for these cases. Cornea Society has come out with a nomenclature for various techniques for transplantation, basically depending upon the what tissue is used, either conjunctival or limbal or some other form of source of epithelium. Then is it the patient's own tissue autographs, or is it from another a person or a cadaver, so on and so forth. So once the autographs, limbal autographs caught on for bilateral diseases, people described limbal allograft, but then the problem with those was rejection and then systemic immunosuppression and so forth. Then the cultures came into picture, the conjunctival limbal epithelial culture. Though it is known that we can culture epithelium, it was quite the problem here was having a good facility to culture. Okay, the regulations, all those things were issues. And then in the last decade, from LVP, Dr. Sangwan described the simple limbal epithelial transplant, which has actually taken over the world, if I may say so, by a storm. Okay, this has drastically simplified and made life of us as surgeons, very easy. So now coming to the various techniques, many of these are old videos and, from the time when I was in SN, or videos borrowed from friends and colleagues. So this is the basic gold standard conjunctival limbal autograft. Here the panels was removed, and very old video, so we had done a transplant. And in limbal autograft, from the donor eye, 4 to 5 clockers of the limbus can be harvested, and this is transplanted to the recipient eye, matching the limbus to limbus, making sure that the limbal tissue is at the limbus of the donor tissue. And over a period, we realized, combining limbal transplants with a corneal transplant is not a good option. Okay, so once we started doing this, we realized it's not good, then we stopped it. We just addressed the limbus first, and then once the ocular surface was stabilized, then we thought of a corneal transplant and procedures like that. So that is about limbal autograft. Then keratolimbal allografts, technically little bit difficult to harvest the tissue. Here, after removing the central cornea for a transplant, from the peripheral corneoscleral rim, a thin layer is dissected off, and that can be used to again place at the limbus of the donor, recipient. Here also, we had done a transplant along with the keratolimbal allograft. Now the problem here, as I mentioned before, especially in a country like ours, is systemic immunosuppression. These grafts will not survive unless you consider them as a solid organ transplant and need 2 or 3 drug immunosuppression. Otherwise, the chances of failure is very high, and that is a major problem in our situation in terms of problems, the issues with immunosuppression and the expense involved in these kind of treatments. So kind of faded out, and practically we don't do any of these procedures now. Then came the cultured limbal epithelium. Now the advantage of cultured limbal epithelial transplantation is that we take only a very small amount of tissue from the limbus, about 2 millimeter or so, compared to conjunctival autograft, where we take 4 to 6 clockers of the donor limbus. The biopsy, the advantages, and another advantage is because tissue taken is very small, you can take it from same eye if it is a partial stem cell deficiency. Other eye, you can take it multiple times. And even, if it is a tricycle eye, we can take, if there is a small area of healthy limbus, you can take that, or even you can take 360 degree of the limbus if the limbus is healthy in a tricycle eye. And then you're, transplanting, culturing it on various media or amniotic, and you can actually see the cells growing and make sure that the cells are grown and you have a continuous layer before transplanting. And since it is very small tissue that is taken, there is practically no chance of deficiency at the donor eye. So this is a schematic of how it is done. You take it, various procedures in the lab, either grow it on an amniotic, or you can grow it on 3T3 feeder cells, airlift it for multiple layer, and then transplant it. Basically, what it means is you need to have a very good lab support, and in many places, the regulations are so strict, it becomes quite expensive to do this, and by the time it reaches to the operating table. So the surgical procedure is not very different from what has been shown by Shweta and others. You have to basically remove the pannus from the cornea and around the limbus. Then this amniotic with the grown epithelium on it is put on the surface and fixed. Now we can do fibrin glue to fix it, or you can use a suture to fix it. So this is the initial results, which has shown excellent outcome in these cases over a period of long term. But then the SLET, or the simple limbal epithelial transplantation, was described, which has changed our approach and ease of doing this procedure. Again, the surgical procedure is very similar to what was shown before. Here, after removing the pannus, fix an amniotic onto the surface and the cornea, glue it, because here the glue is essential because you need the amniotic to stay on the surface without any movement. Okay, because as you can see here, the limbal tissue is cut into small places and fixed on the amniotic. So if the amniotic moves, this the limbal bits can get dislodged. So it's fibrin glue is actually essential in this procedure. And then each bit is fixed with glue, and then put a bandage, contact lens, and tarsography. All has been described and discussed here. So these are all pictures from Dr. Sain, who initial cases of SLET which was done. So now comparing SLET with CLET, the advantage is that the most important advantage is that no lab required, very simple procedure, and the success rate, especially in children, is excellent in these cases, in post-SLET cases. So yes, almost all of us do SLET now. Practically none of us in India do CLET, I believe. Effectively restores the normal structure, improves visual, works well, especially in children. And because that we have taken the lab away from equation, it has become a much more affordable and easy procedure. So when you're thinking about managing a stem cell deficiency, it is absolutely essential to know what are we managing, what is the basic cause for the limbal defect or limbal deficiency. Is it a genetic cause, or is it an acquired cause? If it is an acquired, what exactly is happening? Is it a one-time event, or is it a process that is happening continued, like a autoimmune process or an inflammation process? So understanding this is important, and controlling the inflammation, as Dr. Fogla has mentioned before, it is very important that the eye is quiet before we touch these eyes. Then look at the lids, adnexa, and the fornices. You address them. I mean, all these techniques for initial reconstruction, reconstruction of the bulbar surface, all have been covered, and do those. Then always think about tears. Okay, there will be associated tear film deficiency or instability, or both. This has to be addressed before we think about a limbal transplant. And is it a partial or total stem cell deficiency, unilateral disease or bilateral disease? All these factors really decide how you are going to approach this patient. So this is a algorithm proposed. So address the adnexa and fornix, optimize your tears, and then see, is the visual axis involved? If it is not involved, patient is having good vision, why should you touch it? You don't have to do anything, just leave him. Yes, cosmetically it might not be great, but the patient will be functional. So it's a decision, it's a difficult decision there. Most of the cases it is better not to do if the vision is good. So if the visual axis is involved, then decide, is it a partial or is it a total deficiency? Partial deficiency, less than 1/3 of stem cell deficiency, probably what you can do is you can just, what has been described by Dr. Dua as, sequential sectoral epithelial keratectomy. Okay, you can just scrape off the epithelium from that sector alone, put an amniotic, and see how it heals. Most of them settles well. If it is more than 1/3 to total, we may have to think about some form of, replacement or of the limbal stem cell. If it is a unilateral disease, it can be autografts. If it is a bilateral disease, then it is difficult. Do we have to think about a limbal allografts, or should we think about keratoprosthesis? Individual decision based on your patient cohorts and your environment, you have to decide on that. If it is a very moist eye, a patient who is going to be compliant with immunosuppressives and who can tolerate immunosuppressives, probably you can think about an allograph as a first line, or otherwise probably keratoprosthesis might be a good option there. Thank you.
Thank you so much, Dr. Vinay. I think it was a very nice talk. You took us through all the stages of the limbal stem cell transplant. I remember this one thing that I had read by Dr. Sheffer Singh, where he very beautifully said that doing a stem cell transplant or anything is just like gardening. So you make sure that your pot is correct, your soil is correct, it is well hydrated, and it is only then that you put the seeds. So like you said that, make sure that your fornix is good, it's reconstructed, the eye is moist, and only then think of a limbal stem cell transplant. You said that if the visual axis is involved, is there anything else that you look at, like a PROS lens or something? And have you noticed that after doing a stem cell transplant like SLIT, the cornea usually gradually clears over a period of time? So is there anything pre-operatively that you do, like an AIOS2025 or something, to decide what you're going to do with your visual rehabilitation with stem cell transplant?
Always.
Yeah.
You have to, the basic principle here is when you're going to do something, okay, the idea is for the patient to get vision back. So you should have an entire, plan there, okay. Stem cell transplant alone may not help him, okay. So what are you going to do? Okay, so probably that might be the first step to, kind of regularize the surface. Then reassess the patient. Okay, if the scar is not bad, probably wait. Over a period of time, we have seen, the scar density reduce. If the surface is very irregular, even after a stem cell transplant or your reconstructive procedure, then there's RGP or PROS or all those kind of hard lenses play a significant role. Okay. The transplant of the cornea is the last option here. As far as possible, try not to do that. Not because, you can't or you shouldn't do it, but then if you can rehabilitate them visually in any way without transplanting the cornea, that is the best option which we can think about.
So many times, because of the in the patients with chemical injury, unilateral chemical injury grade 6 total limbal stem cell deficiencies, because of the chemical inciting agent, we see endothelial decompensations also. So as you said that success of a combined PK with this lead procedures or is not very great, so we prefer to do it sequentially. So any experience with doing lamellar keratoplasties with such kind of patients?
Combined lamella.
Combined or sequential? Matlab, what would be the approach when it's only
Combined,
the endothelial decompensation that's there?
The lamella for endothelial, are we talking about anterior stromal or endothelial?
Posterior, endothelial.
Probably not as a first step, or not as together with the surface reconstruction, because once the surface is reconstructed, you have a better view. Also, you will be able to assess the stroma much better. Okay. If you feel it is just an endothelial decompensation where the stroma is not really involved, then you can think about an EK. Either a DSEC or DMEC might be a better option rather than doing a full penetrating keratoplasty.
So that's always like preferable to do it sequentially only.
Yeah. So all these things have to be, decided on a case-to-case basis, based on how the cornea is, how the anterior chamber is. All these factors help us in deciding what sort of surgical procedure we have to do.
I think also that what we need to remember is, in an edematous cornea, the healing of the epithelium is also going to be a concern. Absolutely. So depending upon how thick your cornea is, you're going to take a call whether you really want to do a SLIT or a limbal stem cell transplant in this kind of patients. Because if you have a pachymetry of, like in AIOS2025, you will get a delineation. Sometimes the pannus itself will be taken up as a thick cornea. So that delineation needs to be done, because if it's a very thick cornea to begin with, then the healing of the epithelium might also be a concern. So like Dr. Vinay pointed out, I think it's case-to-case basis. Anything, Arif sir, that you want to add? See, you need to come here.
So most of the cases that I've seen where you have a corneal decompensation, you also have a total cataract, and sometimes you have a mid-dilated pupil and secondary glaucoma.
Yeah.
So I think that's the extent, so that
Correct.
you never see an isolated corneal edema and rest remaining normal.
Yeah.
And so I've had a patient like that in the acute stage. We forgot about the cornea. What we did was we reconstructed the surface, but because the cataract was intumescent and white and it was shallowing the chamber, we just went ahead and we removed the lens without putting in an intraocular lens implant. So we reconstructed the surface, put amniotic membrane, And in the later stage, we went ahead, did a IOL implantation and a endothelial keratoplasty. But the patient still has a dilated pupil, he still has raised IOP, might need a tube implant or a cyclodestructive procedure. Those are very complex cases, but I think that always have a surgical plan. I think it's very important. And remember that for the patient, it's a prolonged treatment. It's not like a one intervention that will solve the entire problem. So unless, and don't embark on a limbal stem cell transplantation if your patient is not willing for follow-up and you don't have the time to take care, because a lot of these patients will require evaluation and a repeat intervention, because if you don't intervene at the right time, it will lead to ultimately failure of the primary surgery that you have performed. And don't miss out on the partial limbal stem cell deficiency. A lot of times, the success attributed to performing a limbal autograft is not from the autograft, but from the recovery of the remaining limbal stem cells. Because often we have seen that, even in my cases of slit that we have done, we find that at times when the patient comes back, you don't see all the pieces. You find that if you have put in about 12 or 16 pieces, maybe you see only 6 or 7 of them remaining. So what has happened to the rest of them? I think with the epithelial turnover, some of them get shed off. If you are doing a slit, one thing that I do is I don't put them in the visual axis. I will put my pieces in the mid-periphery, knowing that, yes, because what we are trying to create is a limbal barrier. We don't want the blood vessels or the conjunctival epithelium to invade the cornea. And at the same time, we want each of those explants to provide enough epithelium to resurface the. So I would, depending on how the underlying cornea looks, if the underlying cornea looks relatively okay, I will put my pieces directly on the cornea. I will put a large diameter amniotic membrane on the top as an onlay. And in the center, maybe 4 millimeter, I will make a window in that amniotic membrane, because that would allow faster visual recovery for the patient. And then you put a large diameter contact lens on top. So I think make your plan and then follow that and evaluate. Documentation is very important. You also need to take clinical photograph, because every time you make a drawing, you may or may not be able to remember for each patient how it looked before. And if you are doing more patients, it's difficult to identify between different patients. So I think a slit lamp photo documentation is very important when you manage ocular surface, because you can always go back and review what the patient had before and how the patient is improving. It also helps me educate my patients, because I can show them proof, because their evaluation of success is how is my vision, because that is the only one parameter that they use to evaluate. But if you can show them how the surface is getting better and how the treatment is making, then sometimes it's easier for the patient to become more compliant. Because the vision is something that you will look at it last. First, you want to get the eye to quieten down, the surface to become better.
Just wanted to make one more point, like coming back to your first point, that like it's important to wait for a very long time after slit to allow the surface to stabilize and clear up. So maybe for that you would like to, so there is no hurry, like, once the surface is epithelialized, that means you have achieved a success. But the scarring would over a period of time reduce, and for that probably you would like to use a soft steroid once at night or something for quite a long time, 3 months or 6 months, and you would be amazed to see the surfaces clearing up, and they would do so very well with either a scleral contact lens or an RGP contact lens, and you don't need to do any major surgery to kind of, absolutely.
Exactly.
Quickly
After.
doing the initial reconstruction, wait.
Yes.
Because the corneal remodeling happens over a period. Because patients will push you. They will get surgery done. They say no vision. Then you are tempted to do a corneal transplant. But don't do a corneal transplant. If you just kind of explain to the patient there are blood vessels, increased risk of rejection, wait for. But by the time they come back 3 to 6 months later, sometimes you see that already the vision is getting.
Yeah, so the counseling is the most important
Exactly.
key in that.
then-
Beforehand, only you explain the patient that it will be a very long process, maybe 3 months, 6 months, 1 year. You would like to wait and see how the surface is improving, and then only take next decision.
I think the other important thing that we have been following is most of the patients in India that we deal are children. So before we touch the patient, the most important part of counseling is that, we have to inform the parents about the amblyopia therapy, about patching of the good eye and making sure that the child sees. And we always tell them that only the surgical part is what we are going to do. Whether the child will see or not is dependent on the parents. So, once you put that thing on them, that it's their responsibility to make sure that the child really follows the amblyopia therapy, because the cornea will be clear, but the child will be, 6 by 60 or 20 by 200 because he's not willing
Absolutely.
to do the amblyopia therapy. So I think counseling is something which, like in any other surgery, but in surface reconstructive surgeries, it forms an extremely important part of your thing.
Agree, Dr.
I think we
Sweta.
have.
In our country, both the parents and the children or the patient, they are so worried about missing out school or work that sometimes they don't look at the gravity of the injury or what surgery you are doing. The moment you do a surgery, when can I get back to my studies? When can I, because I have an exams coming up, or when can I? So we need to tell them that you might need to take time off, take a off, because unless you do this, you will not have the kind of result that you want if you don't follow that.
Yeah. I think we have a gentleman with a question. Yes, sir?
Sir, do you always put the pieces over the cornea or Ogla, sir? Do you always put the pieces over the cornea or over the amniotic membrane in slit?
If the underlying surface is very rough and you have had to do a lot of dissection, like a superficial keratectomy, then you may want to first put an amniotic membrane, like an inlay. That means you put an amniotic membrane, refine it with a 9 or 10 millimeter punch, and then put it on the cornea so that the surrounding epithelium or the epithelium generated from the slit pieces will grow on that, because that basement membrane will provide an adequate environment. But if the underlying surface is very smooth, and then you can directly put the pieces, because the epithelium has a good basement membrane to grow on.
But that's usually very rare. Most of
Yeah.
these cases will have a rough surface because of the
Yeah,
dissection.
it's there. Sometimes you
Yes.
find, occasionally
yeah.
you
A
start
good
doing
plane
superficial
that you get.
keratectomy, you find
Yeah.
a very nice clean
Plane,
base.
yeah, yeah.
So you can